Hi, welcome everyone. I'm Paula Bray, the Director of Research at the Sydney Children's Hospitals Network. I'd like to welcome you today to our Advanced Therapeutics series, where we focus on the rapidly evolving space that is advanced therapeutics, as it represents innovative and potentially transformational therapies for children now and into the future. As I begin, the Sydney Children's Hospitals Network acknowledges that our facilities are built on the lands of the Bidjigal, the Camaragal, the Barramadigal, the Cabrogal, the Wongal and the Wadi Wadi. Our services extend across the lands now known as New South Wales. Aboriginal people believe these lands hold the ancestral spirits of those who have come and gone before them. We acknowledge this is, was and always will be Aboriginal land. I would really like today, and I'm absolutely delighted to welcome Dr. Lara Graves, who is a paediatric endocrinologist at the Children's Hospital at Westmead, who has clinical and research specialty in monogenic endocrine disorders. Lara holds interest in advanced therapeutics for endocrinology and is developing a preclinical AAV-based approach for the treatment of congenital adrenal hyperplasia. In today's webinar, Lara will be presenting on current research in gene therapy for endocrine disorders. So following Lara's presentation, we will move into a question and answer session, and we'll really hope to be able to answer all your questions. You can submit those beforehand in the Q&A tab, which is located in the Zoom controls at the bottom of your screen. So if you see a question that's submitted that you'd also like to have answered that's already been loaded, please just upvote that question by clicking the thumbs up beside it. So without further ado, I'd like to invite Lara to begin her presentation. Thank you very much.
Thank you, Paula. Okay, so I am presenting on some current research for gene therapies in endocrine disorders. I'm going to present some case vignettes and why this is relevant to our patient population, an overview of the gene therapy landscape, an introduction to AAV, and then some recent gene therapy research for endocrinology. And this includes research that's in the literature and also some of my own original research. So the first case is a case of Laron syndrome, which is growth hormone resistance. So this little boy was born at 36 weeks to consanguineous parents, and he presented with perinatal hypoglycemia and elevated lactate. A chromosome microarray detected that he had deletions in the last few exons of the growth hormone receptor gene. And his progress was complicated by persistent hypoglycemia until at least 5 years of age, subclinical hypothyroidism, micropenis and retractile testes, as well as pulmonary valve stenosis. And you can see how poor his height trajectory was. This isn't his family. This is just a publicly available photo of people with Laron syndrome. So Laron syndrome is a mutation in the growth hormone receptor gene and results in pituitary dwarfism. There is a new treatment known as Increlex, which is a recombinant DNA-derived human insulin-like growth factor, and it replaces the downstream IGF-1 that's not able to be produced because of the mutation in the growth hormone receptor. But there are many side effects to this medication, including hypoglycemia, which growth hormone deficiency also causes, cancer, lymphoid hyperplasia, intracranial hypertension, and multiple other side effects. So this child from our case, he was started on, he was considered for recombinant IGF-1 therapy, but we had to wait until his significant hypoglycemia had resolved because of the risk of side effects to Increlex. So at age 6.5, he commenced on Increlex, and gradually the dose was increased over 2 months, as is recommended. But unfortunately, this was complicated by severe hypoglycemia, intracranial hypertension, and a skin hypersensitivity reaction. So it was withheld while he recovered, and the family travelled overseas. And then he recommenced last year and was up titrating at a very, very low, slow dose. And he has had some improvement in his growth velocity, which is these last few measurements here. But we really need a better treatment that has less side effects than this. Case 2, or there's a couple of cases here, is on homozygous familial hypercholesterolemia. So I'm taking you back to 1986 when a child was born to consanguineous parents who both had heterozygous familial hypercholesterolemia. By age 2, this child had multiple xanthoma and a very high total cholesterol. The child was started on cholestyramine and a low-fat diet, but this only marginally affected the total cholesterol. The child was considered for liver transplantation at 3.5 years, but this didn't go ahead. The child had aortic root plaque already, and so the decision was made to start simvastatin, which helped reduce the cholesterol to 15 millimoles, which is still very elevated. At 4 years of age, he was considered for plasmapheresis, and then at 6, it was determined that he had aortic root atheroma, early coronary artery involvement, and mitral valve involvement. So he proceeded to liver transplantation at age 6.5. And this really improved his cholesterol. So originally from 35 down to 5. Unfortunately, only a few years after the transplantation, there was a sudden death due to acute heart failure due to the severe narrowing of the coronary arteries, despite having a normal cholesterol. And this is because the cardiovascular risk with homozygous FH is in place prior to transplantation, and transplantation doesn't fix the risk that's already in place. The two siblings that were born subsequent to this child were treated with plasmapheresis. And then fast forward to 2011, where we had our next case. This was a child born to non-consanguineous parents who both had heterozygous FH. And at 2.5 years, the child was seen by a dermatologist because they had these funny little lumps on their skin, and it was determined to be xanthoma, and the child had a total cholesterol of almost 24. This graph demonstrates the complex treatment path that this child underwent. Initially, a low-fat diet, which didn't really help the cholesterol levels very much. And then ezetimibe was started, plus atorvastatin, and this helped reduce the LDLs a little bit. But plasmapheresis was commenced, and you can see how effective this is. However, after plasmapheresis, there is reaccumulation of the cholesterol, and this child had the plasmapheresis disrupted due to recurrent infections of the line and a fistula and thrombosis. And you can see here some of the levels where post-plasmapheresis, pre-plasmapheresis, post-plasmapheresis. So they have these really up and down cholesterol levels. And then finally, the child underwent a liver transplant. So the natural history of homozygous FH is that children on average have their first major ischemic event at just under 13 years of age, and the mean age of death is before their 20th birthday. Mutations in the LDL receptor result in marked elevation of LDL because they're unable to clear it, and 90% of FH is caused by mutations in the LDL receptor. There are some treatment options. Statin therapies work by upregulating the LDL receptor. So in homozygous FH, you often have an incomplete or sometimes no response, particularly when there's a presence of a null mutation. And you only expect about a 30% effect from statins. And so if your LDL is greater than 30, reducing it by 30% means it's still going to be very elevated. Plasmapheresis is an option. However, there's significant morbidity associated with the vascular access and hospital attendance. And finally, liver transplantation is really one of the only options, which will not reverse atherosclerosis that's already accumulated, and it's associated with lifelong morbidity itself. And accessing organ transplantation for children prior to the onset of atherosclerosis can be challenging because essentially the child's considered healthy because we really need to transplant them before their risk increases. There are some newer treatments, including a PCSK9 inhibitor known as evolocumab, but this requires a functional LDL receptor to work, so it's not useful in a null homozygote FH. And evinacumab, which is an ANGPTL3 inhibitor, may have promise, however, as it works independently of the LDL receptor, but it does reduce the HDL levels, which can be associated with increased cardiometabolic risk anyway. There are some newer treatments, including some gene silencing small interfering RNAs that work in similar ways to the antibodies. But the data for the small interfering RNA targeting ANGPTL3 is not yet available. So we really need a better treatment option, particularly for these children with homozygous FH, particularly when they have null mutations. The third case is one of congenital adrenal hyperplasia. A 4-week-old male presented to a small local hospital with vomiting. He was extremely shocked and shut down, and there was very difficult IV access. He required an scalp IV cannula insertion and then an intraosseous cannula for blood collection and fluid resuscitation. And he was found to be profoundly hyponatremic with hyperkalemia. The child had fluid resuscitation, antibiotics, hydrocortisone, and insulin, dextrose infusions, and resonium, and then was retrieved to a tertiary PICU. And in retrospect, the bloods that were collected at the time of presentation confirmed the diagnosis with a markedly elevated ACTH, inappropriately low cortisol, markedly elevated 17-OHP, and renin level. This child had a difficult to control disease, and there was also, this was complicated with some suboptimal adherence to therapy. From age 3, he had a markedly advanced bone age to 7, but was unfortunately lost to follow-up for 2 to 3 years because the family moved away. They returned to Sydney, and by this stage, the child had extremely tall stature. He had evidence of androgenization with acne and tanner stage 3 pubic hair, hyperpigmentation, which is a sign of chronic increased ACTH. He had pubertal testicular volume, and his bone age had advanced to 13 years and 6 months. Stimulation testing confirmed that he had central precocious puberty, and he went on to have pubertal suppression, but he had suboptimal adherence to this as well, with a final estimated mature height being quite short for an adult man. CAH is a monogenic endocrine disorder, and in 95% of cases is due to a mutation in 21-hydroxylase, which causes inadequate cortisol and aldosterone production to sustain life in the severe form. 46XX infants may be born with virilized genitalia, and this is treated with lifelong steroids, but there are many side effects from both over and under treatment. There is always a risk of death from adrenal crisis if there's inadequate treatment or under treatment during a stressful event. An adrenal crisis is the leading cause of death for people with CAH. People with CAH need lifelong treatment with hydrocortisone and fludrocortisone up to 3 times a day, plus increased doses at times of stress. And we really haven't changed this treatment since steroids were first isolated in the 1950s. We're not able to properly mimic the physiological profile, and as I mentioned, there are a lot of side effects. So there are some newer treatment options that people are working towards. There's augmenting the glucocorticoid delivery system, such as with a multi-dose diurnal glucocorticoid, but Westmead hasn't shown superiority in trials and isn't available in Australia. Some people are using subcutaneous hydrocortisone infusions by co-opting an insulin pump, but this is very difficult to administer. It's difficult to titrate the dose, very high treatment burden, and the device needs to be attached to patients at all times. Some other therapies include trying to target the excessive androgen production by using corticotropin-releasing factor receptor antagonists, such as tildacerfont and crinecerfont, but the children still need to be treated with glucocorticoids. And some people are trying to use a 17-hydroxylase inhibitor to block all androgen production. However, this can only be used in prepubertal children, as it also blocks the production of gonadal sex hormones. So in all of the cases that I've presented, our current standard treatments have deficits, whether that's due to intolerable side effects or incomplete control of the disease, and none of these treatments offer cures. So this brings me to advanced therapeutics. If we could repair or replace the defective gene, could this be a solution? And right now, there are over 4,000 gene, RNA, and cell therapies in development. Gene therapy is on the cusp of revolutionising the modern medical management of an increasing number of diseases and brings previously inconceivable treatment options to reality. The Sydney Children's Hospitals Network has been involved in some of the first AAV-based gene therapy delivery to children in Australia, and there have been some excellent outcomes. Zolgensma, which is now on PBS, has improved the phenotype and survival in over 40 infants with spinal muscular atrophy. Luxturna, which is subsidised through the National Health Reform Agreement, had over 10 children with RPE65 deficiency have been treated. Their disease progression has halted, and some of them have even had improvement in their vision, which wasn't expected. And children have been reporting they can now see the stars in the sky at night. We currently have a clinical trial for an AAV9-based treatment for Duchenne muscular dystrophy, and this is the first in the world to treat children under the age of 5 years. And these recent successes pave the way for future genetic treatments, but the challenge now is to extend to diseases that are more difficult to target. So what is vector gene therapy? Gene therapy is a vector-mediated therapy that introduces genetic material into cells to replace or compensate for abnormal genes or to make a beneficial protein. In some definitions, CAR T cells are also included in gene therapies, and these are T cells that have been modified to express a chimeric antigen receptor, and it's often used in cancer therapies, but I'm not going to go into detail about this in this talk. There are two main types of gene therapies. One is ex vivo, where cells are collected from the patient, treated with their gene therapy, and then delivered back to the patient. And the most common vector in this scenario is lentivirus. And then there's in vivo gene therapy, where the gene therapy is delivered directly to the patient. Vectorology exploits the viral ability to deliver its own genetic material to a host cell. And about 42% of gene therapies in development are using in vivo therapies. The number of studies using gene therapy has increased exponentially over the last 10 years since some major technological milestones. This shows the preclinical in dark blue and then clinical trials, as well as pre-registration for gene therapies in the world. And there are now 31 gene therapies that are approved for clinical use in the world, with a further 2,000 or more in development. Of the gene therapies that are targeting rare diseases, 54% of these are oncological rare diseases. In Australia, we have 6 or 7 TGA approved gene therapies, 4 CAR T cell therapies for cancer, 2 for rare diseases, and 1 Hemgenix, which has provisional approval for haemophilia B. And of the 1,000 or so gene therapies that are being developed for rare diseases, 8 of the top 10 were oncological, with some of the non-oncological top rare diseases listed here. And the graph that I showed you with the exponential increase in gene therapy, you may have noticed there's a bit of a plateau over the last couple of years. And while gene therapy development may be plateauing, there is an increase in messenger RNA-based therapies, which some consider should also be thought of as gene therapies. And this is likely as we recognise that RNA-based therapies have increased safety profiles. For the 340 or so RNA therapies being developed, 7 of the top 10 were non-oncological. And these therapies have an advantage because the cargo that they deliver is only transiently expressed, and there's no chance of genomic integration. AAV remains the leading in vivo gene delivery system, and over 89% of gene therapies in development are using viral vectors generally. And as I mentioned earlier, the AAV is the predominant in vivo delivery system. So what is AAV? AAV is a small virus that includes two main genes in its genome enclosed in a protein shell known as a capsid. To make a recombinant AAV, the viral genome is removed and replaced with a promoter, a transgene, other regulatory elements. And the capsid, or the protein shell, helps determine the species-specific tissue tropism, the vector manufacturability, and immunological properties. And one of the critical advantages of AAV is that the recombinant AAV2 genome may be cross-packaged into any capsid serotype in order to target different tissues more efficiently. And these serotypes may be naturally occurring or bioengineered. AAV delivers its genetic cargo by binding to a receptor on the cell surface, entering the cell and then entering the nucleus. The genome is uncoated where it concatemerizes, and then using the host's transcription machinery, the newly introduced DNA is then transcribed into mRNA and then translated into protein. The newly introduced genetic material is expressed directly from the viral genome and doesn't reliably integrate into the host genome. And this is the premise behind standard AAV-based gene transfer, which is a gene addition strategy where the new gene is delivered to compensate for the faulty gene. The vector genome remains episomal, and this works well in non-dividing organs such as the central nervous system and eye, but it will be lost during cell division. So this strategy has less applicability to organs with rapid growth during childhood, such as the pediatric liver, or organs such as the adrenal gland that are continually renewing through life. So another strategy for these dividing cell populations would be gene editing, which is where the host's DNA is directly modified. The native locus is stably altered by either inducing insertions and deletions known as indels, which disrupts the native genes if you wanted to knock out a gene, or with the provision of a donor template, you could potentially repair the native locus, which will then retain physiological gene expression. And because it's integrated into the host genome, this modification is then able to be passed down into daughter cells following replication. And the first CRISPR-based gene therapy, first CRISPR-based therapy was approved last year, a product known as Casgevy, which is used in the treatment for severe hemoglobinopathies known as sickle cell disease and transfusion-dependent beta thalassemia. The cells are collected from the patients and then they are edited before being returned back to the patients, which is very exciting. So now let's talk about some endocrine research. So starting with Laron. In 2022, there was a publication using AAV8 to deliver the growth hormone receptor gene with a liver-specific promoter to a mouse model of Laron syndrome. These mice were treated at about 4 to 5 weeks of age, so they're weaned, but they're not yet adults. They're probably adults from about 8 weeks of age, so it's kind of like a teenage mouse. There was some partial improvement in IGF-1 levels, shown here in blue, and some improvement in their body weight and length. However, the mice ended up with significant obesity. So it's exciting because this is the first time it's been used in Laron syndrome. Gene therapy has been used in Laron syndrome, but that more optimization is required before we could consider this in humans. For familial hypercholesterolemia, there was a clinical trial using AAV8 to deliver the LDL receptor gene, which was completed in 2020 for patients with homozygote FH. But funding for further development was withdrawn by the biotech company and the results have not yet been published. So this hints that the trial may not have gone as well as hoped. And while AAV8 does transduce the human liver, there are recent developments in capsid technology that have found far superior options. And also, even if this did work well, it wouldn't be appropriate to the growing pediatric population because simple gene addition is lost when cells are dividing. So really, you need to have a gene editing approach for pediatric homozygote FH. And in 2020, a group published the use of dual AAV vectors to deliver CRISPR-Cas9 and an LDL receptor gene repair template in a mouse model of homozygote FH. They used a homology-directed repair strategy, and the mice were treated shortly after birth. And then from 6 weeks of age, they were commenced on a high-fat diet and then harvested well into adulthood. The mice who received both of the CRISPR-Cas and the LDL and the donor template vector had improvement in their total cholesterol, total triglycerides, and LDL, but it didn't quite reach wild type levels. But still, this is really promising, and it may allow the use of statins in this cohort because now they have a functional LDL receptor. The group behind the first CRISPR-based therapy, CRISPR Therapeutics, who made Casgevy, are also currently undertaking a clinical trial using a lipid nanoparticle to deliver Cas9 to knock out the function of the ANGPTL3 gene. Naturally occurring loss of function mutations in this gene are associated with lower cardiometabolic risk due to reduced LDL, reduced triglycerides, and reduced without any negative effect on their health. The non-human primate data shows promise with reduced triglycerides, and a phase 1 trial is currently underway with Monash Hospital in Australia as one of the sites. What is promising about this is the ANGPTL3 gene does not require a functioning LDL receptor, so it has potential for efficacy in homozygote FH. Interestingly, LNP uptake is generally considered to occur due to the LDL receptor presence, but the formulation that this team have used is still able to be taken up in the liver, even in LDL receptor null homozygote mice, which is very promising. And now I'd like to talk about CAH, which was the topic of my PhD, so I will go into a little bit more detail about this one. So there's been a handful of previous attempts to develop a gene therapy for CAH. In 1999, an intra-adrenal administered adenovirus vector was attempted with some efficacy, but the result was lost after 40 days. In 2016, a team used AAV to deliver the 21-hydroxylase gene intramuscularly to mice. And while they had a trend to effect, their results were not statistically significant. And then more recently, in 2017 and 2018, 2 groups used AAV to deliver 21-hydroxylase to mice. One group found a good effect for at least 15 weeks, and the other group found that the effect was lost after 8 weeks. But following the success in the murine model, the team that had the effect for 15 weeks then followed up with non-human primate studies. They did a dose escalation study using AAV5 to deliver the 21-hydroxylase gene to some macaques. But when you look at their data, they had a higher vector copy in the liver than the adrenal at all doses at all time points. So note that the y-axis here is different. So the liver had much more vector than the adrenal gland. There was a gradual reduction in vector copies over time, and the vector was able to be detected ubiquitously. Nevertheless, they've proceeded to a clinical trial where humans have been treated with an AAV5 capsid using a ubiquitous promoter and the 21-hydroxylase cDNA. The first adult was injected in early 2022, and they've injected 2 adults at each dose. They report that the treatment has been well tolerated in all participants. There was a single serious adverse event at the very lowest dose, but that fully resolved, and it was thought to be unrelated, and no further skin reactions were seen. So this is the dosing schedule that they've used. So the first 2 patients had low dose, then middle dose, then high dose. And due to the success with the high dose, they've started to treat people at even higher doses. This shows the cortisol levels, which I've converted to our units in the 2 patients who received the high dose. You can see that patient 5 has had improvement in their baseline cortisol from 105 to 234 with but it doesn't say whether this was a morning stimulated, a morning sample or not. So as I alluded to, they had a steep dose response with the higher dose. So this is measuring 11-deoxycortisol production, which is the interim step between after 21-hydroxylase before cortisol production. And between the medium dose and the high dose treated patients, there was a marked improvement. So that's what led them to try this even higher dose. However, their plan is inherently flawed, as the adrenal cortex is in a state of constant cellular renewal, and differentiated zonal glomerulosa cells arise from populations of stem and progenitor cells that are located in the capsule and outer cortex. And as these cells migrate centripetally, they undergo lineage conversion to populate the cells of the deeper zones before they apoptose at the border of the medulla. And these differentiated cells undergo very minimal cellular replication. As we've shown, the AAV readily targets the zona fasciculata, but it's more difficult to transduce the zona glomerulosa, which is where the progenitor cells lie. And so if you're using AAV-based gene therapy to deliver gene addition to the adrenal gland, the resultant episomes will be lost in these actively dividing cells. And this was demonstrated nicely by Ron Crystal's group in 2018, where they were able to transduce the zona fasciculata very well, but the transduced cells were lost with time, as was the phenotypic effect. And so as demonstrated in the non-human primate data, when you use a ubiquitous promoter and a non-specific capsid, you will have expression of the vector DNA systemically. And most AAV capsids do target the liver, and the majority of the expression of this gene therapy will probably be from the liver during this trial rather than from the adrenal gland. And we sought to investigate this further by using a liver-specific promoter so that we could specifically express 21-hydroxylase in the liver only of a mouse model of for CAH. And we thought that with the increased progesterone buildup due to the 21-hydroxylase deficiency, this progesterone would enter the systemic circulation where it would reach the liver, be exposed to the AAV-delivered 21-hydroxylase, which could convert it to deoxycorticosterone, which would then spill back over into the systemic circulation and return to the adrenal gland for downstream production. So we delivered the 21-hydroxylase to the liver. This is the vector genome copies and the RNA expression. And you can see that there was no vector expressed in the adrenal gland here in red. Therefore, any effect that we see is entirely from the liver. And this is some slides from the liver showing the 21-hydroxylase protein expressed in the treated mice. So with liver-specific expression of 21-hydroxylase, we partially rescued the phenotype. We had improvement in adrenal hyperplasia, shown here in red, compared with the untreated in purple, but didn't quite reach wild-type levels in blue. And this effect was visible macroscopically here with the treated mice compared with the untreated. We also had improvement in corticosterone production. This is corticosterone as well. All mice, except for one, had an improvement in their dried whole blood corticosterone post-treatment compared with baseline. There was improvement in aldosterone production and suppression of their renin expression. So this indicates that the phenotypic effect seen following treatment with AAV with a ubiquitous promoter may be due to gene expression in the liver rather than in the target organ. And in the clinical trial, they may actually see a persistent effect despite the anticipated adrenal cortex turnover, because the liver and muscle are very stable organs in adults. And so it'll be difficult for them to ascertain the source of their 21-hydroxylation effect. So realistically, we need a gene editing strategy to treat congenital adrenal hyperplasia. And we need to be able to edit the genomes of the progenitor cells to ensure that the daughter cells maintain the correction. And so we've been working towards this by using recombinant AAV-delivered CRISPR-Cas and a donor cassette to repair the mutant locus in the adrenal glands of the mice. So we were able to successfully edit between 4 and 12% of 21-hydroxylase alleles in the adrenal gland. So this to measure this, we used a digital PCR to quantify the junctions between the native exon 1 and the donor. We also quantified reverse inserted junctions where the donor is accidentally inserted in the reverse orientation, and unedited alleles. And you can see that there is about a 2-to-1 ratio of the correctly inserted donor to the reverse oriented donor. And there was no editing events detected in the Cas9 or donor-only controls. Between 26 and 77% of transcripts detected were edited transcripts in the adrenal gland, and there were no transcripts detected in the liver. This is not surprising because the strategy that we used captures the native 21-hydroxylase promoter, which does not normally express in the liver. So we were able to show that all our phenotypic effect is from editing in the adrenal gland. And despite a small editing events, we had a big phenotypic effect with increased progesterone here, corticosterone in pink and green, compared with untreated in red and blue. Pleasingly, the mice who received the donor cassette only did not have an effect on their corticosterone, which indicates that the effect that we're seeing is not coming from the donor cassette alone, it's coming from the integration of the donor cassette into the mouse's genome. All mice had improvement in their whole blood corticosterone levels from baseline when they were treated with both of the vectors. Aldosterone was overproduced, which we're not 100% clear on why. Renin expression was reduced back to wild type levels. Aldosterone synthase expression, it reduced, but it didn't reach wild type levels. So this persistent aldosterone synthase expression may explain why there's an overproduction of aldosterone, probably from chronic upregulation of the aldosterone synthase gene. And despite improvement in the corticosterone production, we did not get improvement in their progesterone levels, which is the buildup before the 21-hydroxylase block. We did have improvement in the adrenal mass in the treated mice, which was also visible macroscopically. So while we have shown that we are able to deliver AAV, to deliver CRISPR-Cas9 and a donor cassette using AAV to repair the mutant locus with a phenotypic effect. And this is the first time that this has been shown to occur in the adrenal gland. And while we may not have edited the progenitor cells, we have demonstrated that the 21-hydroxylase locus is amenable to editing. And we are working on some other studies to try and target the progenitor cells. And we could easily repackage this strategy in another capsid once a progenitor tropic capsid is determined. And we're also working on delivering Cas9 as messenger RNA packaged in a lipid nanoparticle to improve safety. And this is the content of one of the PhD students at CMRI, Eva van Dijk. And the reason we want to do this is because when you deliver Cas9 as messenger RNA, there's no promoter. And so not only will the Cas9 not be able to integrate into the host genome because there's no DNA, there's no promoter that could accidentally integrate into the DNA and accidentally turn on an oncogene. And so with transiently expressed Cas9, we limit the prolonged editing events and improve safety. So my final topic is just a little bit about type 1 diabetes. It's not a monogenic disorder, but it's an autoimmune disorder that results in destruction of the insulin-producing beta cells in the pancreatic islets. In 2017, a team attempted to overexpress IGF-1 by delivering AAV8 with IGF-1 DNA directly into the pancreatic duct to try and promote beta cell longevity. And they were able to delay the onset of autoimmune beta cell destruction in a mouse model for type 1 diabetes. And they also improved the glycemic profile of the mice who already had beta cell destruction. Another strategy is to try and reprogram the existing alpha cells to start producing insulin. And so a team was able to deliver via the pancreatic duct genes to reprogram the alpha cells to become more beta-like. And these beta-like alpha cells were then able to start producing insulin with normalization of blood glucose within 5 weeks of treatment and maintenance of normal blood glucose for 7 months. And this study has been repeated in non-human primates. The non-human primates weren't able to completely get off insulin, but they had a 10 to 50% reduction in their insulin requirements. And there is plans for this to proceed to clinical trial. Another strategy is to combine cell therapy with gene therapy. Islet cell transplants are currently used in a very select population of those with type 1 diabetes. And these transplantations are the cells are infused into the liver, and this can restore glycemic control, but the islet transplants usually only live about 5 years, and they require immune suppression for both rejection of the donor islet cells, and because type 1 diabetes is an immune-mediated disease, we need to prevent the body attacking the insulin-producing cells again. There is a limited supply of deceased donor islet cells, and some patients will need multiple transplants from multiple donors just to restore their function. So this sort of a strategy is really limited to very severe cases with profound hypoglycemic unawareness and who are also simultaneously receiving a solid organ transplant, such as a kidney transplant. So to get around this, Professor Shane Gray and Professor Toby Coates are working on a phase 1 clinical trial to try and edit the donor islet cells so that they can evade the immune system. And they've done some mouse studies which delivered TNF-AIP3, which encodes the A20 protein, which limits immune responses. And when they delivered this to mice, they had improvement, they had glycemic restoration and graft survival in mice who were transplanted with the islets that had been pre-treated with the A20 gene therapy. And so recruitment for this trial is planned for this year, but I haven't seen any updates yet as to where that is up to. And a similar study is being undertaken by CRISPR Therapeutics, the same people who delivered Casgevy, and they're using a very similar strategy where they're genetically modifying the islet cells before transplantation, but these islet cells are coming from stem cells from the patients themselves. So the trial is ongoing, but there's no real data available yet. So in summary, treating monogenic and autoimmune endocrine disorders with gene therapy has promise, but there are many challenges that remain that we need to address before the widespread use. And this includes the delivery of the genetic material to the target cell or organ, durability of the therapy, because due to the immune response we have to these viral vectors, we can only receive an AAV-based gene therapy once in a lifetime. There is some work being undertaken to try and work out how we can engineer an AAV to evade the immune system, but we're not there yet. We also need to work on efficacy. How many cells do we need to transduce to have an effect? And how can we ensure physiological control of these new genes? And of course, there are always safety concerns with these therapies. So it's important that clinicians understand the biology and are aware of the associated limitations of these therapies, but they're coming. So I just want to thank some people who've helped me with my gene therapy journey. And I'd like to take any questions. Thank you.
Thank you so much, Lara, for such a fascinating presentation. And thanks so much for sharing your insights and knowledge with us today. Yes, so just a reminder to everyone that if you've got any questions, please use the Q&A function or even the chat function if that's what your preference is. Yeah, it could be questions, comments, anything that you'd like to raise. So far, there is no questions, Lara.
I just
that I can see.
explained everything so well.
You did so well. There was no room for any questions. I guess there doesn't seem to be any questions or comments.
So what I've presented is obviously not a comprehensive review of all the gene therapies in development for endocrine diseases, but it's I can see that, for example, Aaron Schindler's on the audience list, and I didn't go into endocrine bone disorders, but I'm sure he'll be able to contribute to that knowledge soon.
Great. It's just fascinating how far we're going, and you know what we're kind of, I guess, what's coming our way, and very exciting.
It's coming very fast, and we need to be ready, because it's very
Yes.
exciting, but there are definite limitations that and it's not gene therapy is not a perfect option for everybody.
Yes, exactly. It's not the miracle that everyone, it's not necessarily the
Not
miracle.
necessarily. It is a miracle in some instances, definitely.
Yes. Yeah, absolutely. Well, I guess if there are no questions or comments, I'll pass it on back to Paula. But yeah, thanks from me.
Thanks, Ezra. Thank you. I think we've just had one question come through. Prashant, thanks for joining us. Do you want to go, Ezra?
Sure. So Lara, the question is, are many of the newer targets addressable by single AAVs, or do they need more than one AAV?
So the AAV cargo is about 4.7 kilobases. So it depends on what you're trying to deliver. So if you're using a gene addition strategy and the gene that you're trying to deliver is less than 4.7 kilobases, then that's fine. You can use a single AAV therapy to deliver it. And that's what's being done for SMA, RPE65 deficiency, and Duchenne muscular dystrophy, the ones that we're doing currently at Sydney Children's Hospital's network. They're all strategies that are using a single AAV with a single genetic cargo. When you start getting into more complex gene therapies, such as when you're trying to deliver a gene editing, the Cas9 DNA is currently quite big, and so you need to have two different vectors, one to deliver the Cas9 cargo and one to deliver the donor vector. There are some other vectors that have a bigger cargo capacity, but the AAV seems to be safer than a lot of those other vectors. So that's our choice at the moment. But really, with AAV-based editing, we're moving towards delivering the Cas9 via lipid nanoparticle and then the donor vector by the AAV. So that's sort of where the strategy is moving to.
Thanks, Lara. Two more questions have come in. The next one is, hi, Lara, good to see you on the screen presenting your PhD work. Oh, sorry, it's from Alina. So continuing on, well done. Can you comment on the dose of each strategy that you used and how they compare?
So with the liver-directed gene addition strategy, I used 5x10 to the 11 vector genomes per mouse, and that's kind of an average dose. That's probably our standard dose for liver-directed gene therapy. With the adrenal gland, that was a little bit more challenging. I tested the guides initially at 5x10 to the 11 vector genomes per mouse, and we weren't getting any indels in the adrenal gland. So I increased it to 2.5x10 to the 12 vector genomes per mouse for the Cas9, and we were getting good indels at that dose. And then some other work that Samantha Jin has done in our lab is looking at the ratio of delivering the Cas9 vector to the donor vector, and she's determined that we can deliver less donor vector than the Cas9 vector. So I delivered the Cas9 vector at 2.5x10 to the 12 vector genomes per mouse, and the donor vector at 1x10 10 to the 12 vector genomes per mouse. So it was quite a high dose to reach the adrenal glands and get the effect. I do wonder if we used a more adrenal tropic capsid, whether we'd be able to reduce that dose, but we really just wanted to see if we could get an effect at this stage, since it's the first time this has been attempted.
Thank you. And the other question is from Hannah. Great presentation, Lara. Considering the trajectory of gene therapy development for CAH, what might you say to couples planning a pregnancy who are both found to be carriers of CAH on reproductive career screening?
I wouldn't be using gene therapy to guide their decision about decisions that they make in that situation. I don't think that the current clinical trial for CAH is an appropriate treatment for children, not only because we don't know whether the adrenal gland is turning over and at what rate in humans, but even if the effect that the adult humans are getting is from the liver, babies, I can't remember what the how quickly they double the mass of their liver, but if the effect is coming from the liver in that gene therapy, babies are going to lose that effect very quickly. So it's not really a therapy that's appropriate in the pediatric population yet. So I would be counseling them based on current evidence-based therapies, which would be hydrocortisone and fludrocortisone, and not counsel them about gene therapies. It's too far away yet.
Thank you. I can't see any more questions or comment. Oh, there's one more coming. That's great. So that's from Prashant. In high turnover cells, how do you think AAV-based gene therapies might compare to non-viral approaches, given the need for potential redosing?
So you can't really redose AAV-based gene therapies. So you can't use them in, you can't use a standard gene addition strategy in a high turnover organ. Non-viral therapies, you can redose, but it depends on the half-life of the protein that you're delivering. So with lipid nanoparticle, the mRNA is only present for a few hours. And so if you were trying to deliver, for example, the 21-hydroxylase mRNA as a lipid in a lipid nanoparticle, you'd probably have to be redosing them at least daily. So it's not really an option yet. How with the combined therapies where you give a lipid nanoparticle to deliver Cas9 and an AAV to deliver the donor vector, you generally deliver the donor vector first, and then maybe a week later or so you deliver the lipid nanoparticles, so that the AAV delivered genetic cargo is all ready and at the right cell for that burst of Cas9 that's only going to be there for a few hours before it goes. But you can redose lipid nanoparticles. Just redosing daily is probably not a very useful thing. And I can see Anne McGuire's just commented on the last question, that when you're doing genetic counselling for CAH, pre-implantation genetics should be considered in a couple who are both carriers for CAH.
So much to everyone. I think I'll pass it on to Paula now.
Fantastic. Thank you so much, Azra, and most importantly, thank you, Lara, for that excellent presentation and an absolute tour de force across endocrine AAV gene therapies, particularly at the end. So I just want to extend a really warm thank you, and thank you to all the participants for some really great questions and engagement. And just to note that the video of this particular webinar will be available on our website, on our YouTube channel. So if anyone wants to go back to revisit it, will be available. And please also note that there will be a short survey at the end of the webinar, so that if you do have a moment, there will be a QR code that you can complete. Other than that, I'd just like to really extend a warm thank you to our contributors, including Luminesce Alliance, and really, again, like to thank all of you for your participation as we've gone through the day. Please stay updated for our next webinar. And as I said, there's the QR code. If you have a couple of minutes, please do have a look. That would be fantastic. We'd love for you to join us at our next webinar. And please do have a wonderful weekend, everyone. And that's all for today. Thank you.